Thank you for that, that introduction. And what I wanted to do was, you'll see some of the same data as you heard, but my charge was really to start to think a little bit about the biomarkers. You know, how do we actually identify who's a responder and who isn't to the immunotherapy agents? And the key question is, do we have a reliable biomarker? So this is the answer, at least in my opinion, and then I'll go on to justify it. But the answer is that we have right now one reliable biomarker that's working across tumor types in GI, and that's microsatellite instability. And so if we can have the audience remember, the one take-home message from that is don't forget to test MSI. Even in patient populations that have lower rates of it, it's a fairly inexpensive, easy test to do, and it can have pretty profound implications for getting availability for therapies. But having said that, we'll dive into some of the other data and share some of the data on neoantigens, both the idea of mutation load, viral infection, immune infiltrates, talk a little bit about the idea of an interferon gamma response, the immune microenvironment, and then the microbiome briefly as well. So when we think about what it is that we're trying to get the immune system to do, it's really to identify non-self. And this can either be through expression of proteins that are not normally seen, that may be embryonic, for example, or otherwise suppressed, that are overexpressed. There is a little bit of a risk that those have been edited out by the immune system. But really these neoantigens, you know, mutations and alterations that are not seen by the immune system tend to elicit, in general, the greater immune response. So when we think about what it is that we'd like the immune system to engage on, it's neoantigens. As an aside, fusions actually look like they may even be a little more antigenic than other, for example, single nucleotide polymorphism alterations in tumors. But it's anything that shouldn't be there that the immune system acknowledges. So I think you've heard a little bit about this before, but this idea that that there's a whole range of mutation rates here. And I think the key thing is that these mutation rates are not a given, but this really is a number of times that you can spin the roulette wheel, right? Because it is a bit stochastic about how many of these mutated sequences actually are antigenic. And the best estimates that I've come across are really that around 5% of any mutated sequences really can generate an immune response. Now, that immune response may be blunted by other factors, but this idea of just displaying a mutated peptide on the surface in the context of an HLA. So when we think about a mutation rate, it is just that, you know, higher chance that one of those will be antigenic. But that also means there's a bit of an overlap, that you can have patients that may have just stochastically a higher antigenic response, even if their mutation load is not that high. Now, if we go back to idea of, well, what do we know about mutation load? Well, there was some data that says even before the era of immunotherapy, that mutation load is prognostic in metastatic colorectal. And so if you'll look here, the MSS and MSI-High, of course, MSI-High have higher mutation load. But if you look at that curve, this is presented by Dr. Innocenti last year, and we're going to try to split that bell-shaped curve of microsatellite stable, in essence, in half. And when that's done, even within the MSS, so this is MSS only, what you can see is that when that optimized cut point of 8 mutations per megabase were used, that the mutation load was prognostic. So that just reiterating that there are other components besides microsatellite that may play a role. So this is a reminder that, of course, we're talking about a number of different activating and inhibitory signals. And if we focus on PD-1, which, as you heard, is where most of the work is ongoing, and this is a nice kind of summary, it was alluded to earlier, a nice summary of response to PD-1 inhibitors and mutation rate. And you can draw a line, and there's a little bit of a correlation there, but certainly a lot of outliers. And I've circled there the GI cancers. And one of the things that really comes up is, of course, pancreatic is down to the bottom left, where you'd expect with a low mutation burden and low response rate, but that the mutation rate does not perfectly correlate with response. And as was noted, the microsatellite stable colorectal cancer is the one in the bottom in the middle, where one would have predicted a response rate of about 15 to 20% based solely on the number of mutations. So while this is lower than MSI, clearly there's something else going on if we're going to make this broad generalization of mutation rate and disease response. Okay, so I won't belabor these points. You've seen these studies, but I'm going to dive into some of the biomarker subgroups within a few of these to try to understand this a little further. So nivolumab and MSI-H, the Checkmate 142 study, you saw some of the curves. One of the questions that comes up is, well, what about PD-L1 expression? Now, the caveat with all these is that there is some variability in how positive and negative PD-L1 is confirmed. There's been anxiety about finding the right monoclonal antibodies to stain these and making sure that there's a commonality in how we're calling this. But what you can see is that there's not really a strong correlation with response and PD-L1 expression in MSI-H colorectal cancer. If you look now not on the tumor, but on the tumor-associated immune cells, that likewise not a correlation that was strong and seen here. So the second analysis that was reported out was the impact of BRAF mutation status. And I think there was some thought going into this that there would be differences because they really are very different context. But the reality is that whether you look at BRAF, which denotes a sporadic, or the converse, a clinical history of Lynch syndrome, which is the hereditary subgroup, there's really no correlation. And this is where I would, if I was a high school teacher prepping people for their final test, that's where I'd pause and point out this slide because it may be relevant for a question that will come back later. Right, but this idea that there is that MSI-H response to PD-1 inhibitor independent of BRAF, independent of hereditary syndrome, independent of PD-L1.
No child left behind, right?
Right, no child left behind. We're going to make sure everyone passes this exam, right? Thank you. Okay, so really a bit intriguing, but this is in the setting of colorectal. What about if we look at some of the other studies? So here's the other Nivo-IPI study, the Checkmate 32, esophageal gastric setting. And so here the conclusion was that there was clinical activity irrespective of PD-L1 status. You can see perhaps that in these different cohorts that the response rates may be trending towards higher rates in PD-L1, although the robust statistics didn't quite hold that up. But you can see certainly in some of the combination regimens, 40 versus 22, 23 versus 0%, that there could be differences by response rate. What about nivolumab in HCC? So the interesting thing about HCC is it's one of our 2 or 3 GI cancers where there's a viral etiology. And here, they're going into these studies, as you can see from the study designs, there was thoughts that these cohorts may be very different, that they could have different side effects, but they could also have different efficacy because of the viral antigens. And so this study was designed to really look separately at no viral hepatitis versus HCV and HPV. And what was seen, and I apologize for the small size here, is that progression-free survival, no different across all the cohorts, 4 months to the decimal point across all those different arms. And overall survival, and likewise, no difference there as well. So that was, I think, think we were expecting to see a little bit of a difference there, but really not seeing that. And part of this may be related to this idea of in HCC that there's really, during the chronic infection with Hep B and C, you get this, this T-cell exhaustion phenomenon. So this is kind of well-established mechanism whereby chronic infection can persist, so it doesn't get cleared. And part of this could also then apply to how the tumor responds to the tumor responds in the setting of PD-1. And so this is probably one of the reasons, at least, why we don't see much of a difference between those. Now, what about PD-L1 in HCC? Here, what you can see is in the two different cohorts, the differences here by PD-L1 status. You can see the response rates, kind of objective response rates of 12%, 19% in the PD-L1, less than 1%, but 27, 26% in those with greater than 1%. So back to this sense that there is a bit of a difference by PD-L1 status with this methodology, with this antibody in this tumor type. So the other viral, one of the other viral ones that we deal with is anal cancer, HPV associated. And so this is work done by Van Morris at our institution and Kathy Ang. And this is 39 patients enrolled, a response rate of 24% in this in the ITT population, with about a 6-month duration of response. So this led to nivolumab being added recently to the NCCN guidelines. So that is another recent addition to the guidelines. Now, what about the biomarkers? So here, there was a very nice, although small numbers, but all the patients underwent biopsies. And of those, we had 12 that were evaluable for this. And what was seen was that the PD-1 and PD-L1 in the tumor cells were both associated with response to therapy. And you can see both by IHC there as well as the quantification. So this would be another one where there's at least a sense that that correlation is holding. Now, this was also one of the studies that actually looked in the biopsies at the CD3 and CD8, so the Tcell infiltrates. Now, we don't see this very often in a lot of the correlatives for our trials, because these are usually fairly heterogeneous, kind of hard to quantify, especially in pre-treatment biopsies where you can get a kind of a scant core. And so kudos to the team for really being able to do this well. And what was seen here is, again, probably not surprising, the more T cells that were there in the pre-treatment biopsy, the higher the likelihood of response to the PD-1 inhibition. So what it showed was that like we have seen in a few other sets, that this idea of T-cell infiltration and PD-L1 activation tends to be correlated to some degree. So just as a reminder that we've known for many years that the T-cell infiltrates can be prognostic, and this is reminding us of work from Jerome Galland, the Immunoscore, which is a bit of a difficult score to do technically, but actually gives very nice readout in terms of prognostic information in earlier stage 1 through 3. And at least an updated data appears to be somewhat independent of MSI status. So we know that these infiltrating T cells can be quantified, but it's just a bit difficult to do. So in the nivolumab, I think, these are small numbers, but I think the trend and the theme is something that we'll continue to see. It's this idea that if you have a T-cell infiltrate, cytotoxic T-cell infiltrate, that can be a good predictor of response, but also presence of PD-L1 on the expression independently can be a factor, even if the T cells are not very high. So why is that? And I think this is kind of an important point, even if they're not an aficionado of the immune biology, but just acknowledging that PD-L1 is really a reaction to the interferon gamma response. What does that mean? It means that a reactive T cell produces an interferon gamma response, and that can then signal through a JAK-STAT pathway. And this can, as a result of the interferon-related transcription factors, can result in PD-L1 expression, right? So the tumor cell, in defense and response to this T cell engaging, can then put up the PD-L1 blockade. So it means that that there is a component, certainly, of when we're seeing PD-L1 expression in tumor cells, that's a sense that even if you don't see the T cells there may be an interferon gamma response that could be underlying it. And that's where some of this, the biomarker work has really been trying to look at this duality. Now, as a bit of an aside, for those that have been following the melanoma work, it turns out that there's a bit of a yin and a yang to this signaling, and that this interferon gamma can also result in growth arrest and apoptosis in the tumor cell, which would seem to be a bad thing. But the thought is that benefit of PD-L1 expression outweighs the downside for the tumor in this signaling pathway. But what's been seen is one of the mechanisms of resistance that can occur is that you can get mutations in JAK. And what this does is it now, once that you have blocked the PD-1 with an inhibitor, now there's only downside for this signaling pathway, right? The good side, the upregulation of PD-L1, is no longer beneficial in the setting of the immunotherapy. So now there's selective pressure to lose the signaling through the JAK pathway. And so that's why you see New England Journal of Medicine papers talking about JAK mutations as mechanisms of resistance in melanoma. So that's exactly what's going on. Now, how prevalent are these in melanoma? They're certainly seen, but they're not, it's only a small wedge of the mechanisms of resistance. But I bring this up because anecdotally, we're seeing patients with mechanisms of resistance, including B2M, the MHC expression loss and MSI-H, and then we'll be presenting some data about the role of JAK mutations in MSI-H patients in a month or so. So it's going to be, we'll have to look at how the mechanisms of resistance may occur in these settings. Okay, so moving on to, you've seen the cobia tezo data, so I won't belabor this. Here is the waterfall plot, and I think, as was mentioned, we were hoping that the higher response rate would hold. But one of the most exciting things in my mind about this was some of the correlatives that came out of it, and really this kind of concept that the MAP signaling was a key component here. But one of the reasons that makes me think this is a real phenomenon and this combination does have some biologic effect, even if it's a smaller response rate, is data like this, which shows that when you look at a bulk tumor and look at the MAP kinase signaling, which is probably predominantly from the tumor itself and not from the infiltrates, but what you see is that the MAP kinase gene expression signature, when that's elevated, these are the patients that are having an improvement in progression-free survival. So we'll see what MBLAZE shows. It may be that if we're doing this in all comers, it may be pretty close to see whether or not it beats regorafenib in the randomized phase 3. But there may be a subset here that we just need to better understand that may be the responders. So stay tuned to this story. I think this will be something we'll see. So the final few slides are really trying to think about the immune microenvironment. And I think simplistically we can simplify things in, at least in colorectal cancer, although these themes apply elsewhere, in talking about tumors as inflamed tumors. These are where there's infiltrating activated lymphocytes. Immune desert, there's just nothing going on, no sign that the immune system has engaged at all. Or what's called immune excluded, where there's an engaged immune system, but this microenvironment prevents activity. And it turns out fortuitously that the consensus molecular subtypes, which are an RNA-defined subgrouping for colon cancer, really tend to very nicely align with these immune contexts. And so this has led to another series of efforts to really say, what is it that we can do to leverage that? So just to visualize, on the left, lots of T cells inside. On the right, this is a nice example of lots of T cells around the periphery of the tumor, right? They're in the region, but they're being excluded from actually engaging substantially into the bulk of the metastasis. And CMS4 is really in between there. So there is a moderate T-cell infiltrate. It may not be quite as high as CMS1 or MSI-High, but there is this clear subgroup of immune-excluded colon cancer that may be our next area to really focus on outside of MSI-High, where there's at least some degree of immune engagement already. So what are the thoughts? How are the field moving forward? So for CMS1, the MSI-High, there's studies of PD-1 LAG-3. We saw the CTLA-4 data. And Immune-2, you really need to get a robust response. So this is to begin with, where you need vaccines, the bispecific, CEA, TCB. And then CMS4, with this immune excluded, there's been interest in the TGF-beta pathway. And why is that? Well, in melanoma, TGF-beta can nicely separate responding and non-responding tumors as part of a signature reported in Tcell a few years back of this innate PD-1 resistance. And so this has led to work, including some published just 2-3 weeks ago in Nature, showing when you do a PD-1 and a TGF-beta together in a mouse model that you can suppress this immune environment. And then the combination here of a PD-1 and TGF-beta recently published as well that's demonstrated results. So it happened that there was an M7824 study, which is a bifunctional agent against PD-L1 and TGF-beta in patients that are heavily pretreated. And there was 2 responders on the study, one of which was mine and is now still ongoing for about 1.5 years or so. And in profiling, it turns out that indeed that the CMS4 is associated with this response. So this kind of, based on that strong biology and that clinical signal, there's now a phase 2 study that just opened last week for CMS4 subtype patients looking at TGF-beta and PD-1. And the final thing, because we can't talk about biomarkers and immunotherapy without acknowledging that there's a lot of interesting work going on in microbiome. I won't go into the details of this, besides to say that there's some commonalities that have been seen across studies, but there's a lot more differences between studies as well. And so what we're at the point now is that there's been some interesting hints, but we need to kind of have a better sense of what exactly it is in the microbiome, what bacteria in particular may be the most relevant, or what family. So pay attention to this. There's now intervention studies trying to alter microbiome that are kicking off as well. All right, so conclusions is mutation load nor viral association really explains the differential response rates in GI tumors. PD-L1 expression and on inhibition appears to be tumor specific, right? I showed you some situations that where it shows either way. The immune infiltrates and this interferon signaling PD-L1 expression pathway, kind of stay tuned in that area. That not all GI cancer non-responders are really immune deserts, right? That there is probably a middle ground where the immune system is engaged partly, and that it's some additional blockade from the microenvironment. And how we can modulate that remains to be seen. I'm not sure we have the answer yet, but that's an area of next hint. And to go back to the very first slide, which is what is the reliable biomarker for this setting? Right now, despite all the past 20 minutes, it's microsatellite instability, and I have to leave you with a reminder, don't forget to test. Thanks.